afternoon, everybody, and welcome to our April CCTST Grand Rounds. We're very excited today to learn some more about the Live Well Collaborative and to hear from two researchers from Cincinnati Children's and their work with the collaborative. Very quickly here, I'm going to hand the mic over to Craig Vogel, who will both talk about Live Well and introduce the speakers. So Craig Vogel is the Associate Dean of the College of Design, Architecture, Art, and Planning, or DAP, at UC, and he's also a co-founder of the Live Well Collaborative at UC. So thank you all for being here, and I will turn the mic over.
Thank you very much for having me here today, and we'll get started. And if you notice on the title slide, we've been the Live Well has been in existence since 2013. Slight correction is 2 years ago, I stepped down as Associate Dean. When Robert Probst left in his role, I stayed 1 extra year, and now I'm basically a faculty member, professor in the College School of Design. And as I'm phasing out, it looks like by next December, I'll go to emeritus status. So that's the full update on that. So next slide, please. I'll just do next after this. So I'll be introducing the Live Well side of this, and Mary and Sarah will talk about it from their side as experiencing as one of the teams, one of the representatives of the teams we've worked with. So you can see here, it'll be a general overview, talking about our work and our process, and then get into case studies. So next slide. So what's interesting is we started with Procter & Gamble, and interestingly enough, they were very interested in 50 to 60-year-old women consumers, because as many of you might know, it's still the case that if anybody gets a call and they're over 50, normally the group that calls asking for consumer information will say, thank you very much, but we're not interested in talking to you. And what they realized is that 50 to 60-year-old women were controlling more than half of the income purchases, or the purchases for homes. And so we helped to start on that basis of bringing more understanding to older consumers, and that's the Live Well was founded with that theme as a nonprofit C6. So we're unique in that we're between UC and P&G, and what that means in a C6 is that we do not own the intellectual property of the projects that we do. And we bring a design thinking process as an innovation lab, which is unique. There aren't many of those in universities, so that's something distinct. All right, let's go next. So we've had significant number of projects overall. We work with students who are undergraduate, upper level co-op, and graduate students, and occasionally PhD. We form interdisciplinary teams, normally driven by design, but will include business, and whenever possible, biomedical engineering students are great to work with, engineering, and occasionally A&S students, and we form our teams based on the project we get. So you can see the number of faculty we worked with. We created a concept called fellows for continuing work after undergraduate graduation, for undergraduate fellows, and then for graduate students. And they normally stay with us for 1 or 2 years after. Next. So these are the companies we've worked with, and the top 5 are the ones we're working with now. And what's interesting, it's only been recently that we've actually worked with organizations, Council on Aging and Jewish Home, that are dedicated to issues of aging. Council on Aging looking at how people want to live at home as long as possible, and COVID has even accelerated that. And then Jewish Home is working with the old aging community within the Jewish community here in Cincinnati. So everybody else has really been looking primarily at how they respond to aging as a company that has potential to make that connection. And so we also worked with the Design College on Aging with Dignity. And so this is an overview, and you can see the 3 key areas, but healthcare has by far become the biggest one we work in. We work with UC Health on and off, but Children's has been consistent since we started about 9 years ago. Okay. And so here's some of the recognition we've received working with you. And these are design recognition. There are publications that have been done on the medical side, and not sure if there hasn't been any awards that I'm aware of, but Mary and Sarah can talk about that, but certainly recognition as we get to the project that I'll talk about, looking at the anesthesiology project. All right, next. So, okay, keep going. So one of the things that we talk about is the concept of value-based human-centered medicine, or human-centered design, which is the broader concept that we work with. And what we found, I became very interested in the concept of translational research, which primarily is defined as bringing something from the lab table to the bedside table. And there's been tremendous evolution of understanding how new possible medication, different kinds of systems can be used to manage and react to children's illnesses, particularly in cancer. But we're looking at it from the other end. What does it take to get people to become, children and families to become active participants in their own healthcare and cross the knowledge boundaries to fully understand the challenges that we face? And that's another kind of translation, but it's more human-centered than technology-driven, but we're normally reacting to or helping technology to be more effectively integrated. Next. So we bring multidisciplinary teams from our side, and what most people don't realize is that 4th and 5th year students, even 3rd year students in DAP, because of its co-op program, have had a number of professional co-ops, cooperatives, before they get to us. So they're not only well educated in a very, very challenging undergraduate discipline for those who are undergraduate, but they're also experienced, and they go in and out every other semester, which is a very impressive program. And they're not only are they fresh, they understand professional practice as well as they understand what they're learning in the university. And as I said before, we use user-centered design thinking, which also comes out of a term that we use in design called universal design and inclusive design. And so that's been being practiced for over 30 years as a very clear part of what designers all learn, how to understand the needs of the people they work for. Next. So this collaborative co-design experience is something that's extremely important. And I have to say that Children's Hospital is one of the best organizations to work for from a co-design. And if you think of design as its basic kind of operation as managing change and creating innovation approaches to changing what exists, all of you are designers, but you bring a different perspective than the designers that we use from DAP. And so the co-design is that we work with you from the beginning throughout the program. All of the stakeholders in children's that are important to a project, we work with all of you and a core team that's the direct contact, but we want to work with as many of the people that are part of the process at Children's, and also families and children directly as well. We use a qualitative approach to begin with because we realize that qualitative approaches using a lot of the tools from anthropology, ethnographic tools, where we can get in-depth insights and interviews. We do direct research, and then we do indirect research by reading. You normally give us information that we use to become functionally literate on the topic. So, and then we'll be able to work with you to create testable solutions in 16 weeks. And as Mary and Sarah can talk about, they can show you what that means from their perspective next. So this is a range of the kind of projects that we've done. And some of you may not know what all of these mean. You may be aware, but when we use UX UI, we're not talking about being programmers. Although there's certain programming of knowledge, and across our programs, some of our students are much better at programming than others. But we're talking about working from people back to software, not software out to people. And we have a very strong ability to create interfaces that are easy to understand, easy to manage. And then we work with your technology groups, with the other people in the project to actually develop them. And it's important to work with all the computer-related programming people from the beginning, so we're not speaking two different languages at the end. A lot of animations that we've done for CBDI, and we'll talk more about that. The graphic print design that you see there is actually our first project with sickle cell that we did with Lori, and that turned out to be the cornerstone of everything we've done, where we showed we could become capable of understanding what sickle cell is and what the issues are, and then work with Lori's team to develop solutions to help the transition of children from children's into independent health as adults. So we'll talk more about the rest, but all of these terms, we'd be glad to explain them more, but it just shows you the range of kinds of themes that we've dealt with. Next. So last summer, Dr. Bain Butcher, who's part of Family Care, doing research there originally here in practice, is also an artist, a painter who teaches in DAP. So he has a co-appointment with medical side of campus and with DAP. And we have worked together on a number of projects, but we looked at the 57 projects that we've done with you, and now we're actually over 60. And so this is the number of grants that have been awarded to CTTST, which is one of the mechanisms to work under the CTTST structure to get support with the funding that you could bring to create matching funding, to create support that enables us to create a team. And you can see the different parts of children's that we've worked with, and that list is right there for you to, so I'll read it for you. So it's incredible range, and in a number of cases, Mary Greiner will talk about the sequence that we did with her, which is one of her most, I think, most complete projects we've done. Next. So these are a few highlights, and we'll talk a little bit more in detail, but what's interesting is look at the center of the foster care guide and then look at the identity portal. That is part of a sequence of projects that started with a foster care eye care guide for children who are leaving foster care to become independent adults. How do you give them the knowledge and information they need to succeed? And so many of children's challenges come from crossing the divide between the incredible care and support they get with the various parts of children's into adult care. And so this is critical for foster care because there's so many holes that problems they can run into. So this was a complete guide. We worked for them. And what was interesting about it is that we thought they were going to want an app, and foster care kids do not want apps because they very often don't have the technology to support it. They wanted a tangible artifact, which is what we produced. And the identity portal is the system that then gives everybody information about foster care children in the region. And so we went from creating a product to be put in the hands of foster care to a system that supports foster care once they become independent. Anesthesia we'll talk more about a little bit later, but being able to solve that issue is a big one, and talk about the 1, 2, 3 device. So we'll talk about these in more detail after. And the eye transition, as I said, was our first major project with you and set the whole kind of basis for everything we've done. Next. So these are some of the statements that we've had, and Dr. Parenthesis has been an amazing champion. And whenever you have somebody that's at the level he is, it makes things so much more effective to get things done. And so the various teams that he puts together to work with us have been fantastic about following up on John's amazing imagination and insight, and things that could be done to make CBDI more effective. And one of it is the video series, which I'll show you a little more about. And so you see these different aspects that when we did our research, we interviewed all the different members of children's that we worked with to get these kind of statements. And so that's another part of creating a clearer understanding of the 60 plus projects that we've done. Next. Okay, quick thing. So what makes our process different than the way you work is that we bring, first thing we need to do is get to know you and understand the topic. So, and you need to get to know us. So in the research phase, we're doing a number of things at the same time. Now the lead-in, I'll talk about in a minute, how we do that. But the research phase is why we start qualitative is we don't know enough to do quantitative research. We're learning qualitatively about you, about the topic you're bringing and the issue you're bringing. And then we'll visualize that in a way that creates what we call a shared understanding. And it was one of the best things we do for you as an organization, because very often you see complex problems in pieces, not as a whole. we model the whole thing, and that becomes the basis for ideation. And then we can do multiple concepts very quickly, and then you can help us figure out which ones are the best and very often integrate them. So very often you might pick a concept and want to move it through very quickly. We can take more time because of our ability to visualize more opportunities to give you the chance to see things that you would never think about because you're really more interested in moving through to get to validity and proof of concept. So again, the refinement we'll show you in a little bit. And then in the case of next steps, putting them into practice. And again, what's been wonderful is after we've tested and refined things, we actually get it out into practice at Children's and then study it further in that regard. Next. So we give a Design 101 workshop, and with CTTST, potential groups with funding will come to one of these sessions, and we'll see if we're a good match for you. And we'll teach you about the design process, much of what I'm talking about today, but in more depth. And then if the light goes on for you, you can then apply for the additional CTTST grant that Dr. Hybe started years ago, and then get a complimentary funding to create the funds necessary to work with us. So a project for a team to work with you is somewhere in the neighborhood of $30,000 to $40,000. And most of you are bringing about 15 to 20 to the table. And the matching fund from CTTST brings it up to enough to support a faculty member and a team to work with you. Next. Okay, case studies. So this is what I was saying. The 123 device was a great example of somebody bringing an opportunity almost by accident. By being on one project, we noticed that there was a nurse performing an activity where she was monitoring the activities of daily living for people who are in long-term care in children's going through chemotherapy, making sure that they showered once a day, that they got out and be active at least twice, and that they brushed their teeth 3 times to offset the impact. Next. So what we did is we took a paper concept, which was most effectively done by the nurse who had conceived of it. It falls off the more different people were doing it without the same kind of insight that she had, and turned it into an interactive device that the child could interact with, the nursing staff could interact with, and parents could interact with. So once a child did an activity, they recorded it on the device. A parent or one of the staff could confirm it, and then it went to a central database to keep a record of that, and then children were rewarded for meeting their goals. And it turned out to increase the number of adherents to the 123 app projects. And you can see that's won several awards. And DMI is Design Management, and Fast Company is a major innovation magazine that gives awards to innovative work. In one of their categories is healthcare. So we could take the concept, create drawings of it in 3D. So we started to model what it could look like. We then actually built 30 prototypes to test, put them into the hospital up in the north hospital up the highway, and we were able to test and see how effective it was. And then because of the fact that the new rule is to not have any extra technology in the room independently, we then have further integrated it into an iPad. So we actually built the circuit boards and the whole device to model, and then we've worked with programming tech side to actually take that same knowledge and put it into an interactive iPad software. Next. So by the way, the first project just ended with the 3D device. Then that was made and prototyped. It was a separate project that transformed it, so it wasn't one semester for that whole thing. So again, this is one of the quotes from that. And Vicki Hickey was the nurse that came up with the concept. And she just couldn't believe how much her insight could be transformed into something that everybody could equally participate in, and that information could be recorded in a central database so they could check and follow children. And this is also something that could be put in all parts of the hospital to understand how children need to behave both in the hospital, but also when they go home, and parents can take over that role. Next. So the video library has really been the dream of Dr. Parenthesis, and mainly because we can go to the next one. What happens is very often different people in the hospital will explain the same condition in a variety of ways, sometimes under describing it, sometimes being so technical that the family has no idea what they're being told, or sometimes with a kind of seriousness that scares people. And you probably are all aware of this, and you know how challenging it is to take your vocabulary and transform it to what's required as a 7th and 8th grade kind of level of communication. So what we started doing was creating animations that would help cross that divide and work with teams to find the right language, the right images to talk about what is a leukemia, which is an incredibly challenging thing to tell a family and try to explain to a child. And so with the success of What is Leukemia, we've gone on to create a whole series of those. And we co-design it with you, and we turn it into a reality. Next. So we have those video library now that's there and accessible to everybody, which again, not only is it accessible across children's, it's accessible to anybody that gets on the website. So we had to create a whole series of characters and then make sure the characters were all representative diversity and thoughtfully created without any unforeseen biases. We do storyboarding and journey maps to help understand how to create the kind of animation before we start to build it. And then we can work across any number of topics now, which has been a terrific kind of understanding of knowledge we've gained in doing these. Next. So again, what we've been able to do is with our videos, with your co-design approach, we've been able to educate patients so that they're more able to be empowered to work with you to create that kind of teamwork that it takes from the family side to your side to accelerate potential outcomes and positive outcomes. Next. So the anesthesia induction app was the first one that actually right now is leading to potential commercialization. And so anesthesia is one of the scariest things for children to go through before surgery, wearing a mask. And I can still remember at 4 years old having a mask put on my face for my hernia operation. That's how powerful that memory is for me. And how to reduce that stress. And so Abby has brought the opportunity and some ideas that she had, and we helped her to develop a solution. Next. How are we doing for time? Okay. So this is the app that helps children to turn breathing a mask and a mask into a game that helps an animal achieve a goal. And by doing that, they do this before and they learn to breathe properly so that it reduces all the fear and turns it into an experience rather than into a frightening kind of pre-op challenge. Next. And so these are the steps: by observing teams, by seeing the process, by exploring concepts of different ideas. First, we thought about a product being the solution, and we kept that idea, but put it into a interface game that they could use, and you can see the child here practicing. It also introduces the anesthesiologist to the child, so they're not meeting for the first time. In pre-surgery, they actually know each other and feel comfortable. So it does a number of things, and it also reduces the results of fear on the outcome side, where that can have lasting damage to the patient in terms of outcomes of the surgery, but also nightmares that some children get. Next. So this is Abby's statement about that. And again, it was great with working with all of you because you also have innovative thinking. All we do is optimize that and show you things that you can do with it. Next. Okay, so the eye care guide, again, I talked about, so we can just go through that. That was the beginning with Mary and Sarah's work with them. And this is the booklet. And on it is all the activities that a foster care child would need to know about. And this is each card can be added or subtracted by a child and keep going. And so you can see the iterative steps in here. And so keep going for that one. And again, Mary will talk about that and Sarah in a minute. And so I'll end there and hand off to Mary and Sarah. And Mary is an associate professor and medical director for the CHEK Center at Children's, and her research aims to understand health risks of children with child welfare environment and evaluate innovative healthcare delivery approaches for children in or at risk of entering foster care. And Sarah, as an associate professor and scientific director for the CHEK Center in Cincinnati, her research explores healthcare and child welfare systems influence on children and adolescent development and how these systems can support young people to achieve better health and psychological outcomes. So I'll hand it over to you two, and you can take it from here.
Thank you so much, Craig. That was such a great introduction and overview to LiveWell, which has been such a great collaboration for us. Is everybody seeing my screen? Great. So as Craig mentioned, I'm a researcher in behavioral medicine and clinical psychology, and also work as the scientific director at our foster care clinic affiliated with GenPeds. And I'm really excited to present this work with all of you today. I'm also going to be answering questions in the chat that are technical or clarifying things, and Mary will do the same when when I'm presenting, that she can answer questions. So with that, I'm going to hand it over to Mary to get us started.
Perfect. All right, let's get started. So we have had the opportunity to work with LiveWell to improve some of the health outcomes that we have seen for children who are in protective custody of child welfare, which is commonly referred to as foster care. And so to get you all up to speed, we're going to start by summarizing some of the challenges that healthcare providers, child welfare staff, and youth and families who are involved with child welfare face in trying to support health and well-being for these children. And by doing that, we're going to describe a set of solutions that we have been able to put out there in collaboration with LiveWell, including iCare2Check. We'll dive in a little deeper there, identity and identity for caregivers. All right, so it's helpful to know as we start that youth in foster care have poor health and healthcare outcomes, even compared to peers with similar socioeconomic backgrounds. And there are a number of reasons for why that is true. But one area that Sarah and I have spent a lot of time thinking about is the role of poor information sharing. And what we have identified is that this lapse of communication, poor information sharing has led to a lot of challenges in these groups. So for example, child welfare, their job is when they identify that a child needs to be removed due to safety and placed with new caregivers, they're often doing so, could be in the middle of the night, it's often in a very urgent or emergent situation, and they often end up placing children with new caregivers who don't have health information about that child. And we're not just talking medical records, complete history, but children might go into care without their medication. So you might have a child with asthma who goes into a new placement without their inhaler, or a child who's placed with caregivers who don't know that they have an anaphylactic allergy to peanuts. We also see a disruption in care when children enter foster care. So there may be scheduled appointments. There may be appointments that have been scheduled for months that the child is finally approaching, and then they come into custody, change placements, and miss those important primary care and specialty appointments. Simultaneously, what we're seeing on the healthcare side is that we may not even know that our child is in foster care, right? If our child presents not to the foster care clinic, but to the emergency room or to an urgent care, to a specialty clinic, the healthcare staff there might not even know that the child is even in foster care. With that, they may get consent to treat from the wrong person. They might be sharing medical information with the wrong people. And they're trying to make treatment plans for a child where they don't totally understand their social history. And so try to develop a plan that involves a lot of caregiver response, say, for a child who's actually in independent living and doesn't have any adult living with them, is really not going to work very well. So it means that we can't develop treatment plans that are in the best interest of our children. And finally, we're seeing that our caregivers themselves and our youth who are actually in foster care have limited ability to get information about either of these systems, either the healthcare system or the child welfare system. And so they are the most profoundly impacted.
So that background really sets up our first project with LiveWell, which started in 2014, which we called iCare2Check. And iCare2Check was really designed to help address the gap for youth in foster care. So what we've known from some of the work that we've done locally and then what's been published in the literature is that caregivers typically are relying on caseworkers or on healthcare providers for health information. And in our study of 77 foster and kinship caregivers, we found that fewer than 10% had access to immunization records for the young people that were placed with them. About a third knew about that child's allergies, and fewer than 40% were aware of upcoming appointments scheduled with Cincinnati Children's providers. But as many of you may have experienced or been aware of, when young people are moving out of their family's home and transitioning into independence because they're going away to college, they're establishing their own health care. Once they've turned 18, there's a lot of reliance on your own caregiver, right? Calling your parent to say, hey, I need my shot record. Can you take a picture of it and send it to me or whatever? When was I diagnosed? When did that surgery happen? All of that information that's missing. So young people in foster care are relying on their caregivers and caseworkers, as well as other healthcare providers to get their health history because they don't have that same connection to a parent who has been with them for their entire childhood to be able to support some of that information transition. And so if caregivers don't have access to that information, then they can't relay that on. And this impacts about 200 foster youth in Cincinnati annually. So we have around 200 that emancipate from foster care between the ages of 18 and 21 and are expected to operate independently in managing their own health. And few of those young people have told us that they know how to access healthcare or access their own records independently. So that was the gap that we were at the start of the iCare2Check study. But we've also established that locally and nationally, young people in foster care are using more healthcare services than their peers, and particularly are using more emergency care and more expensive types of healthcare for non-ambulatory conditions. And so there's an important gap that we need to close in order to make sure that we're keeping this population healthy across their life course. So the purpose of the iCare2Check study was to figure out how to help improve healthcare utilization and health status for young people as they were approaching emancipation or aging out of foster care. And it was really designed with the idea that we would start before they had moved into independent living. So this is sort of the beginning of a transition phase for a young person that's approaching emancipation, where we'd be able to help support some of that information sharing and self-management behaviors through collaborations with the Check Center. And then as young people were moving into independent living, that they would be able to get more information from their caseworkers about how to manage their own health and get some additional training and tools to support that so that they could maintain their own health and continue to be engaged with their primary care provider and others after they had left the child welfare system. So we did a 1 semester long co-design studio that, as Craig mentioned earlier, we thought we were going to start with an app or some sort of technology that would be able to support these young people. But in those research sessions where we went to a couple of the local homeless shelters and worked with young people who had recently emancipated, what we learned from them was that that technology solution wasn't going to work. And what they really needed was an analog tool that was laminated so that it would be durable if it got wet, and they could take with them and they could manually write into what information they needed, and would help with them with all of the coaching that they needed around how to access healthcare services. So this and they also wanted something that was discreet and that they could customize. So LiveWell designed, I've got a couple of the guides here, designed these custom covers that they could choose. The covers are laminated. They're able to take it with them. They can take sections in and out, and they can really change that over time. And we wouldn't have come up with that kind of a solution had we not worked with LiveWell. And then there was a whole lot of prototyping. So figuring out how to use the tabs and what makes the most sense and which icons and how do we want to display information that really helped to guide and inform, and included a mix of consistent young people that were co-designing with us, but also getting new groups of young people so that we could get fresh perspectives and new ideas. And so we were able to develop that and then implement it and test it. And what we found was that for young people who received the healthcare guide, after they emancipated, there was a significantly stronger connection to their outpatient primary care. So they were retaining connection with primary and specialty care at Cincinnati Children's. Whereas that was much lower for young people who did not receive the iCare guide. We did not see a difference in emergency and urgent care use between those two groups. But what we, and I should also add that Hamilton County was a great partner with us for this and now supports the ongoing maintenance of the guide. So we provide those healthcare guides to young people when they're identified as going to likely emancipate from foster care around the age of 16. And then they continue to receive those guides and they're updated with support of a nurse that's affiliated with the Check Center to do that. But we quickly realized that if caseworkers don't have access to this health information for the young person, that then the young person themselves can't complete that ICARE guide, right? So it's really still reliant on it closing another gap. And so with that, I'm going to hand it over to Mary to talk about our second Live Well project.
Perfect. So number 2 will be identity.
Do you see it?
Yes, can you go to the next one?
Yes, sorry.
Perfect. All right, so as Sarah was alluding to, we really needed to understand more about the challenges that our child welfare partners were experiencing in getting information from the healthcare system. And so we were able to do surveys with 52 children's services staff about what their experience was when trying to get healthcare information. And what we learned is that they were spending about 60 minutes per month gathering healthcare information for every child on their caseload. So keep in mind that an ideal caseload may be 20 to 30, a more typical caseload is 30 to 50. That is a lot of time that we're spending on trying to gather healthcare information. We heard that our caseworkers are waiting about 17 days on average for updated information from the healthcare system following a visit. So if you've had a visit and the healthcare provider has made a change in care or treatment plans, it's going to be probably on average over 2 weeks before that information is going to get to that caseworker. It would take them about 15 days to be heard that an appointment was missed so that they could start responding and trying to support that family to get them to that appointment. And they recalled to us that they felt like missing health information was resulting in negative or poor outcomes for their children and families in about 36% of their cases. So more than a third that missing healthcare information was leading to bad outcomes. And the kind of quotes we heard were, I have to request the information even when the child is linked with the foster care clinic. I'm rarely provided with updated documentation. Meanwhile, right, we're hearing from the foster care clinic that they're sending it, but it's not getting there. Inaccurate information provided by parents or caregivers, healthcare providers are not responding, and releases of information aren't on file, information is unknown, provider fails to share it, there's this delay. So even though the information is there, even though there's good intent to want to share it, it's not getting to our children's services staff. Meanwhile, we're seeing the same thing on the healthcare side. And so this is from responses from 11 healthcare staff who told us that affiliated with the foster care clinic, they were spending on average 40 minutes preparing for a new foster care patient visit. So that included getting social history and child welfare history, medical history from other institutions where the child might have been seen, trying to gather all of that together in anticipation of the child coming into the clinic. They reported spending about 17 minutes on average sharing health information with new caregivers. So trying to provide that updated information about allergies, medications, and so forth. They then would spend 15 minutes trying to send or provide child health information with caseworkers. So they're telling us we are writing these reports, we're sending these reports, but they're not getting to the people they need it when they need it. And even on our healthcare side, they reported that they felt like missing health information that was relevant to their treatment decisions was happening about 25% of the time. So 1 in 4 times they felt like they were not making an informed treatment plan for that child because of missing information. And the kind of quotes we got from them is very similar to what we were hearing from the child welfare side. You know, we leave a voicemail with the caseworker with minimal response and frequent need to follow up. We're not being notified when there's a new caseworker for the child, or if our patient has been moved to a new placement, we're not hearing about that. Trying to connect with the caseworker is nearly impossible, and medical records are not updated on who has custody. So it seems, and you can see from these quotes, that both sides are really reaching out and wanting to communicate and share information, but they're not able to. And so to address those issues, this is where we came up with identity. And so the background on how identity works is that information shouldn't be paired one time by email or by file upload. Instead, we need information about children in foster care to be shared with the right people at the right time so that it's available to do our jobs and do our jobs better. And so the way identity works is information is pulled out of the back end of the electronic health record and out of the back end of the child welfare system. Then we run matching algorithms between the two data sets to identify that kid A, who's in the electronic health record, is the same as kid A, who's in the child welfare record. Now we've matched those youth, and then we're able to display information about that young person so that the healthcare user is able to see the child welfare data, like who's in custody and who their caseworker is. And the child welfare worker is able to see healthcare information. So what are the diagnoses for this child? What meds are they supposed to be on? When do they have upcoming visits? And the idea of all of that is to enhance decision-making around healthcare and social services when our children are in foster care. And so our partnership with LiveWell was really important on this because we had identified that there was a communication barrier. We'd identified this near real-time technology solution. But what we knew is that we needed to find a way to make identity something that was easy to use, that was useful, that was efficient, that our healthcare worker side and our caseworker side would want to log in and utilize this because it was so beneficial. Because otherwise it would become another tool that was developed that wasn't being utilized. And it would become a burden instead of a really helpful tool. And so what LiveWell helped us do is do co-creation sessions. And so we were able, in partnership with LiveWell, to meet with caseworkers and healthcare workers and talk them through, what do you want to see first? What's the most important? What should you see as soon as you log in? What can be buried a little bit lower because you might not need that as frequently? Or what should be grouped together because if you see this in your workflow, you're always going to want to see this and want to see this. So how should it be organized? How should it flow? What should go together? What's the most important that we need to highlight and bring to your attention to make sure it matches your workflow and your job? And then we did some fun, Sarah and I call them scavenger hunts, but LiveWell helped us to sort of evaluate how users were able to interact with identity to say, okay, caseworker, you've just got a new kid in your care and you're getting a phone call to say, what medicine are they supposed to be on? How are you going to figure that out? Here's identity. And then watch them go through and use identity, how they're able to get to that and show that they can do it efficiently, confidently, and easily. So we did that on both sides and came out with a product that we've been really proud of. And we've gotten just so much feedback about how easy to use it is, how simple it is. We're even told sometimes that folks from their own institutions will look at their own data in identity because it's easier to see and use there than it is in their own database. And so identity was implemented in March of 2018 after our LiveWell co-creation sessions and development. And we were able to pilot that with 66 child welfare staff and 10 clinicians at Cincinnati Children's. We used that pilot testing to refine with our early adopters, see what was working, what wasn't working, add some things and adjust. And then ultimately used a train the trainer model to spread to all children's services staff, as well as Cincinnati Children's hospitals that were frequently seeing youth in foster care. That went really well. So by July of 2019, we were ready for our full implementation at Cincinnati Children's. So that was 346 child welfare staff, 284 hospital staff here in Cincinnati. And then by June of 2021, it was time to bring on a second children's hospital in a second county because other places in the state were saying, hey, we've heard about this, we want this too. And the great thing about identity is the more groups that participate, the more valuable it gets because you get a more comprehensive social history if a child's had involvement in multiple counties and a better medical history if they've had involvement in more than one health institution. And so exciting to share that in September of 2021, we were able to license identity to CoreData. And CoreData is a healthcare technology group that is spreading identity all over the country. As of our latest count, I believe there are 37 children's hospitals that are currently in talks with CoreData about how they could get identity to their institution. So we are seeing great impact already, and we've got some studies we've completed and many more in the works that have been really exciting. Most importantly, I told you from the healthcare side, we weren't even sure which of our kids were in foster care and which weren't when they were presenting around the hospital. So we've been able to use identity to create a flag within the electronic health record that's updated every day. So we have perfectly accurate information to say, yes, this child's in custody, make sure you're getting consent from the right person, that we're sharing information to the right person, and then sends you to the identity portal where you can get additional information about who is that current caseworker, if that's changed, where is that child placed, and other information like that. We've also seen an improvement in that information gathering period. So we told you kind of about how much time was being spent with those new patients coming to the foster care clinic. After implementation of identity, we've been able to see 38 minutes of information sharing served per patient seen in the foster care clinic. And so that's freeing up time to do more outreach and follow-up and some of the other work that we want to complete. So we're seeing more complete and accurate information about each child, which has been really relevant as we talked about, like permanent or temporary custody, which informs decisions with COVID vaccination. We've also been seeing up-to-date Medicaid numbers. So this is a really big deal that historically we didn't have the new numbers that a child gets when they come into the foster care system. So we weren't able to bill for the services that we provide. And a foster care clinic, as you can imagine, is on a really, really tight budget. And so we need to be able to get every penny that we bill for in order to keep those doors open. And so getting that number directly from child welfare has allowed us to bill the right person right up front and recuperate the payments for the services we're providing and keep our doors open. Most importantly, out of all of those is that we're seeing indications that we're providing better healthcare. So children in custody are required to have these state mandated exams within 5 business days of coming into care and with every placement change. The goal about that is to try to decrease some of those gaps in care I was telling you about. And we've seen by using identity, instead of waiting for someone to reach out to us, we can reach out proactively and say, hey, identity has let us know this child's had a change of placement. We now have the new number for the new placement. We'll call the placement and say, hey, we saw you've got a new kid in your care. Why don't you come on into the foster care clinic and we can make sure you have your up-to-date meds and so forth. And we've seen a 40% increase in compliance with those exams. We've also seen an increase in primary care for our kids and less duplicated care. We've seen a similar impact on the child welfare side. And so we have youth are available in identity within about 24 hours of entering custody. And we're seeing that access to critical health information really works on demand. Whereas before, caseworkers were kind of waiting until they got this report on their desk 2 weeks after we saw the kid. Now they can log in whenever they're ready. So if they're about to do a placement change, they can log in right then, see what's going on with this kid, what's the new information I need, what are the allergies, what are the meds. They can prepare for school enrollment when you need a lot of medical information, including immunization records. That's available in identity, and they can prepare for court as well. It's organized, it's easy to find the information they need. And what we've learned from measuring after implementation of identity is we're saving about 1.5 hours per child per caseload. So that's a caseworker, an hour and a half that they are now able to spend on securing support for a kinship caregiver, or school enrollment, or something else to really help that child and family. So we know our caseworkers are getting our information from identity. The next question we had is, was that information, meds, allergies, and so forth, trickling down to the caregivers who are providing the day-to-day care for that child?
Sorry, I lost my mouse to unmute. So really quickly, sort of closing this gap, thinking about now the caregiver, which is sort of where we started, right? The caregiver needs the information to support the kid. And our most recent studio session, which we just wrapped up with LiveWell this past fall. So we told you earlier about the gaps in information that we had identified when families were supporting young people in their homes before identity was implemented. And we really expected that once identity was available, that caseworkers would have this information and they would relay that information to caregivers. But what we learned was that even though in about 50% of cases after identity was implemented, caregivers reported that they were receiving a printout from the identity system. So there was something out of identity that a caseworker was handing them. We didn't see any meaningful change in knowledge about things like upcoming appointments, allergies, and immunization records that are already in identity. So what that told us was that this information first of all, is not quite making it that last mile to caregivers for everyone, because we're only seeing this happen 50% of the time. But even when it's making it, it's not designed and shared in a way that caregivers can actually use. They're not learning anything from these beautiful printouts that we've generated with caseworkers in mind. And so we worked with LiveWell to do this latest studio design, in which we started again with co-creation sessions and prototyping, except this time it was really focused on those caregivers. And so LiveWell came to our foster care clinic. They talked with caregivers who had recently taken children into their homes. So they were in the process of trying to navigate this journey right now, and got feedback from them about how information should be displayed, how they want to manage situations where they have multiple kids in their home from different families of origin, what they're going to do if that kid is coming from a group home rather than from another kind of family or kinship placement. and how they were going to navigate that whole entire process, and did several prototypes that were then tested with those caregivers in that clinical setting so that they could really get that experience up front. As well as feedback from caseworkers and clinicians saying like, yes, I want you to alert this if this happens, or please no, we're not going to share this information because it's confidential and caregivers shouldn't have access to private information about teens' reproductive health, for example. And that ultimately led to a new version of identity that's been designed specifically with caregivers in mind, that we're now in the process of developing the beta version to be able to test with caregivers. And so that sort of wraps up that really we can't emphasize enough the importance of having a collaboration with organizations like LiveWell that can bring that design experience to bear, so that we can all understand how we can share information, but not just the information itself that needs to be shared, but the way that it's designed and structured and the environment and context in which that information is coming, that really does lead to advances even in high risk underserved populations where they are limited in those resources and can be financially sustainable as well. So with that, I think we have about 10 minutes, maybe a little less. So it looks like 8. So I'm going to stop sharing and turn it over to Stephanie and others for Q&A.
Thank you so much, Sarah and Mary. Oh, we got Dreen already in. Come on, Dreen. Don't hesitate. Unmute.
No, I know my like video, I don't know what the deal is. I turned it on and it's not coming on, so I really
It's okay. Your painting is beautiful.
It is
Thank
beautiful.
you.
It is.
My question is, I've always loved this work, and I've been watching this work sort of unfold over the years. And one of the pieces of the work that I have been extremely personally interested in is the I wish I could remember what you called it, but the card deck of health life.
Well, the iCare guide.
Thank you.
Yes.
And I have been personally interested in that because it has so much applicability across populations outside of children who are being served in the foster care system. And I was wondering, about thoughts about using it in other populations, and B, how to begin thinking about it, or would you be interested in helping people move it into those populations? And I'm going to give you an example. Kids with developmental disabilities transitioning into adulthood.
So I cut that out for time. So it's like you were like ready and poised. We did adapt a version, this is it, for kids that were in 2020. So kids that were experiencing juvenile justice involvement and were going to be released from detention, that we worked with LiveWell to design that's not specific to foster care, and also had like binding and other things that were allowable within the Juvenile Justice Center. So we've adapted it there. It's also been implemented in Massachusetts. So we've made some adaptations that are like, so that it's not Cincinnati centric. So yes, let's adapt. We would love to. That would be great. We've done it before and we'll do it again, is what I'm saying.
Thank you.
And I should say we did also work with this is less relevant for internal, but for external people, we worked with our group to be able to give that license so that they are able to do that free of charge, as long as you're not trying to also make money off of selling it.
Hey, Sarah?
Yeah.
Hi, this is Brett Harnett, Biomedical Informatics. Oh, sorry. I'm familiar with what you do, thanks to Craig and other members of your team. But have you officially engaged with the Digital Futures ecosystem yet?
I don't know what that is. Mary, do you?
That's the new building right next to you. It's the large building on I-71. The building just represents the physical space, but this is a program out of the UC President's Office that's been in development for the last 2+ years in terms of, involving community, solving problems that matter, leveraging different types of expertise across the institution and the community. So there's a definite alignment with what you do and what they intend to do. So I'm going to take that as a no. You have not had a conversation.
I'm aware of some of the building at Ames, but I would say no is a fair answer, that we are not engaged with them, but it sounds like maybe we should be.
Okay. Okay. But I may be part of the Digital Futures from BMI standpoint. And so part of what we'll try to do is make connections where the connection makes sense. So,
Okay, great.
I hopefully will help you with that.
Awesome, thank you.
Dreen, you still have your hand raised or an asset or a comment or?
No,
Just-
my hand still raises because I'm very
Nope.
digitally.
Don't worry.
incompetent right now.
Don't worry.
No,
Don't worry.
I do want to say first off, thank you so much for presenting this work. I have also tapped into Live Well for help with my research, and it's a great experience, and it does provide you with a perspective that you will not get just doing the research on your own. And so that is something that I did definitely appreciate. And I love watching what you and what Sarah and Mary are doing with their populations and their interests. I think it's just amazing. And I hope that you guys continue doing the good work.
Thank you.
I agree. This was fascinating, and I'm amazed and always inspired by people like you. So thank you. I hope that doesn't sound cheesy. I hope it's sincere and genuine, and you guys always deserve a lot more credit than you get. So thank you again for spending your lunch hour with us, and really educating us. And I see Craig in the middle
Hi.
here. Go ahead, Craig.
Sure. Hi, so I just wanted to add to the idea of digital futures. We have a number of faculty that have worked with us that are going to be centered there. And I don't know if you're all aware of what Renee Seward is doing with her work, and she's going to be one of the leading researchers out of Code for helping children with learning disabilities, which is fantastic. The idea that that's digitally centered is a little bit different, but connected to what we do, since so much of what we do is connected there. So we're also looking how 1819 is going to be a connection to Digital Futures. We have at least 3 faculty that are actively involved there as well, and they're people that work with us. So Ming, and one of our faculty out of architecture, one of our faculty out of mobility, they're going to be centered there. So it's a great continuation, and we will look to see how we can be complementary and connected there as well. So it's a good point to bring up. Also, anybody who wants to visit LiveWell, if you haven't been there, I didn't mention Linda Dunseith. Linda Dunseith is the executive director, and I go and talk about stuff, and she makes sure it gets done. So if you want to have a visit, you should contact her, set up visits, and if I can be there, great. But she's the primary coordinator of day-to-day, and she's a terrific colleague. So.
Yeah, she's great to work with. Let me put her email in the chat for you. I also have in the chat our evaluation. So please fill this out for our presenters and topic today, but also to let us know what kind of topics you'd like to hear in the future. Oh, good, Sarah. You think it's worth seeing? I enjoy going over every time as well. There's so many different types of office space over there, but I do enjoy being with Live Well, and we presented a team science workshop for DAP over there, for DAP faculty, thanks to Craig. So appreciate it, Craig.
Sure.
All right.
So thanks again for the opportunity.
Unmute and say that, It is fun. It is fun. We're allowed to be a little bit goofy on Grand Rounds. It doesn't have to be so stuffy, right? Exactly.
Well, there was super important work that we shared that we're really proud of, but it is also a really good time. It's a great environment, and it's creative, and it's fun, and we made new connections and friends through it. We still talk to the folks from our very first project we are still in contact with now, and so it's just been a really neat experience.
Yeah, absolutely. And it's the old Sears building, and then has a new facade. So it's just really cool. It's
Yeah,
just really
actually, the
cool.
front is the original facade cleaned up, and the back is an office building. It's kind of a great fusion of two worlds of history of the city. So it's very nice.
Yes, it is. Well, thank you to Craig, Sarah, and Mary. Catherine, thank you again for introducing us, and have a great weekend, everyone.
Okay,
Thank
take
you.
care.
Bye, everybody.
Bye.